Can we have the slides, please? Okay, so in the next 15 minutes, I was listening to the previous speakers, and everybody has been talking about infrastructure upgrades, and I'm sure as we increase the infrastructure, you also need to understand how do you serve these hospitals. People have talked about primary health centers, district hospitals, community health centers, but I'm sure we need more innovations, and this is what it's all about. How does a specialist reach the last mile? We are all specialists. I'm a critical care physician, and as any other specialist doctors, we would want to run our specialties more in metros, but how do you reach the primary guys is the main concern, and that's where the systems comes into play. And there are various forms of telemedicine that have been discussed yesterday also. Answering on a WhatsApp is also a telemedicine, which a lot of doctors do. But what do you do with emergencies? Because in the emergencies, what makes a difference between life and death is what you do in that first 1 hour. And in that 1 hour, if the junior doctor at the spoke gets enough help from a specialist, 24/7, that's what can make a difference between life and death. So we all know that if you compare with developed countries, our doctor-patient ratios are quite low. This is the data from the US. And if you look at our data, it's as good as 0.75 doctor per 1,000 population in India. But if you look further deep, the specialists are actually in more shortage. So this is a photograph of me in the younger days when we used to run emergency command centers in various cities in India. We are still doing it. So since the topic is about tele-ICU or emergency, what is it? If I were to summarize it for you, this is nothing but a huge cockpit where you get all kind of data flowing into the specialists who are sitting in that command center. Now what happens is that you can see the doctors here. Actually it's a monitoring system. So the spoke system has something. They are connected to the hub, and you are continuously monitoring emergency patient and ICU patients from the command center. It's a blend of medical technology and IT systems, because that's what is needed to actually, we believe, deliver the healthcare to the last person in the line. What does it do? It only focuses on the critical care outcomes. So the aim is to actually, why are we doing healthcare? Why are we discussing all these things? We are discussing because we want to save more lives. We want to reach more people. But we all know reaching the people is a very difficult job. We can create infrastructure, but we still have to understand how do you serve those patients. Now this only focuses on the emergencies. It's not an OPD system. We have to focus on the emergencies, and that's where the life and death counts most. It uses the resources from the existing systems. We can upgrade the resources, but as I told you, I believe we are doing a lot to create more and more doctors, more and more nurses, but the specialist is still very, very niche. While we can put up Ayush doctors, we can put up junior doctors, we are actually empowering nurses to do OPDs, which is very good, because this is the way it happens in various countries. But they still need the specialist in emergency scenarios, because that's where the training counts the most. So, and that's what the system should focus on. It is nothing but a system of alarms, and you keep on talking to the doctor, the alarms keeps on flowing in, the specialists here keep on advising the doctors on the alarms and the patient management. So it has 4 components. One is a software which throws in the alarms. As you can see, there are red, yellow alarms. The red ones will be responded immediately because they are life-threatening. And then you can see the yellow alarms, which the consultants will take some time to react to, because they are not the life-threatening alarms. The other component of this is the hardware, so that you can see the patient, you can focus on the ICU monitor, you can focus on the ventilator, you can see the data from there. And the third component is the connectivity, which is not an difficult thing these days. And the fourth is the availability of the specialist 24/7, 365 days at the command center. This is a critical care specialist who is helping these patients. This is where our journey started. This is a small baby. It was in 2010. This baby was operated for a cardiac surgery in a remote state in India and was stuck on the ventilator. Those were the time when 3G was launched, and we just had nothing but a tablet to save this baby. He came out of the ventilator. It was a 4-year kid, still coming on follow-ups. And that's what our belief as critical care physicians started, that we can actually run ICUs remotely also. And the systems have come a long way now in those 9 years, but this is how it all started. So it has its own benefits for everybody. For the junior doctors and nurses, they know that their consultant is overseeing their patients every time. So it is good for the doctors. Obviously for the patients, because it has been proven in various medical journals to decrease the mortality by 50 to 60%, and we have also published our data from India, which shows that we can reach that outcomes. Obviously for the hospitals is benefits, because in the smaller hospitals, it gives the same level of critical care which you are aspiring in the larger cities, which is the tier 1 cities. And obviously for healthcare providers, because it is a completely expandable solution, you can actually reach the last person in the queue, and you can actually reach the last mile. This is the core team. For want of time, we are actually trying to show you a live round, which is a demo round today. We still have 8 minutes. The idea of presentation was to give an overview. We'll try to run around here, and unfortunately, we cannot show you a live patient because of patient medical privacy issues, but we'll try to show you how it's done. So I have Dr. Milind Talegaonkar. He's there. He's acting as a spoke ICU, which is a smaller emergency area. And then we have the software running on this side. And as I told you, there are 3 components: the audiovisual, the software, the specialist, which I am acting at the command center, and the connectivity. So Dr. Milind, good morning. How are you? Dr. Milind, can you hear me? Maybe I need to go there. Dr. Milind, can you hear me?
Yeah, I can hear you.
Good, good. Good morning. You have a new patient. Can we discuss this case?
Yeah, I have just received after our batch this patient, which is 55-year-old gentleman with history of hypertension, and came to us with history of 5 days fever, high grade fever with cough and expectoration, and he presented in ICU with blood pressure of 90 by 60 with 100% sodium, and he was looking sick. So we have initiated this fluid resuscitation. We have resuscitated him with 1 liter of fluid, and his initial SpO2 was very low, which was 86%, and we have started high flow oxygenation, which is near about 10 liter of oxygen. Now his blood pressure is after initial fluid resuscitation, his blood pressure is 100 by 70, and he is maintaining saturation of 92% on 10 liter of oxygen. I have just initiated non-invasive ventilation also.
Okay, Dr. Milind, what I would suggest is that you have got a 55-year-old male who has a high blood pressure and he's come to you with some infection. Am I right? I think you have given 1 liter of fluid. If you look at the vitals, I can see the vitals here. The blood pressure showing is about 105 by 65. This is still very low as compared to a person who is used to high blood pressures. So I think you should give 500 ml of saline more. And as we are talking, the critical care staff is writing these notes, and she'll send you the advice simultaneously. Second, I think because the blood pressures are low, I think you should add noradrenaline 0.05 mics per kg per minute, so that by the time the fluid takes effect, the blood pressure can be maintained so that the patient doesn't suffer multi-organ damage.
Yeah.
Okay? And third, I want you to do 3 things. One, can you do an acid-base analysis or show me an X-ray of the patient?
I have just received first ATG,
Okay.
which is showing, yeah, which is showing pH of 7.29 with SXS of -10 and lactate of 10. So
Okay.
is it severe metabolic acidosis?
Can I see it on the renal parameter, sister? Yeah, no, we have got it. So the pH is 7.215. The patient has a high carbon dioxide. The patient has low oxygen.
CO2 is 75.
Yes. And the patient,
CO2 is 45.
yes, so I think you need to give more fluid because if you don't, the patient most likely is dehydrated. You need to give more fluids because the base excess shows that he's very, very hypovolemic. If you do not correct the dehydration, there's a chance that the kidneys will go for a shutdown. I think you should give 500 ml more of normal saline, okay?
Okay.
And repeat, do we have the X-ray or can I see the ICU monitor?
Yeah. Just wait for a minute.
Okay.
We are ready.
I would like to see the heart rate and the other things on the monitor.
Sure, sure. Within second you will get it.
Yes. In the meantime, Dr. Milind, can you tell somebody to prepare for the ventilator because his carbon dioxide is high. The patient will need a mechanical ventilation. Okay, the X-ray is here.
Yeah, I have already ordered for the preparation of intubation and initiation of the ventilation.
Okay, so the X-ray shows bilateral infection or pneumonia in the lung. That is why the oxygen levels are low. We know the diagnosis. Can you give first shot of antibiotic immediately? Because that will definitely help him.
Yeah, I have ordered the antibiotic. Within next few minutes you will get it.
Okay, so the choice of antibiotic in this case should be injection meropenem. Sister Neha is entering it. Give it 1 gram stat and then we will change the dose according to the renal parameters of the patient. Is that clear?
Sure.
Okay. Neha, are you writing all the physician orders and sending it to him? Okay, good. So can we look at the ICU monitor now?
Just wait for a minute. We are focusing now.
Good. Okay, great. I can see the vitals from here also. He has a heart rate of 106. Oxygen level is still borderline, it's 91. And the respiration rate is about 23, 22. So I think it's better to put this patient on ventilator and then let's look at the vitals again.
Sure. We have just initiated the process.
Okay.
In next few minutes you will get intubated and we will initiate the ventilation.
Neha, can you show
Right
me
now we
the,
use the non-invasive ventilator.
fine. Can we see the ventilatory parameters, Sister Neha, when once they have intubated the patient? Let's set the ventilator for them. We will go to the respiration. Okay, yeah, I can see the ventilator now.
Sure.
Please confirm once you have done the patient on the ventilator.
We are just initiating. Within next few minutes we will correct.
Okay, so is the patient been put on the ventilator?
Yes.
Okay. So I can see the ventilatory parameters on my software, okay? And I can see that you have to give 100% oxygen, which is explainable. What is your tidal volume on the ventilator?
This is 300 ml.
Wow, wow, that's great. What is the weight of the patient that you are taking?
This is near about 60 kg.
Okay, if you are taking 60 kg,
98.
300 ml is a good,
98.
good. And I can see the ventilator on the screen now. Can somebody go away from that screen? Dr. Milan? Somebody is standing in front of the ventilator screen.
Yes, we are just trying to move him away from
So I can see that you have set an oxygen of 100. I think ventilator is done. How is the blood pressure now? Is it better after ventilation?
We have just started non-arterial support. After initiation of the non-arterial support and fluid resuscitation, we are getting blood pressure of 110/70 with mean blood pressure of 65, which is just borderline, but
Okay.
still he is in requirement of the non-arterial support.
Okay. Has injection meropenem been given as the advice has been sent to you?
We have just ordered, and within next few minutes we will get it.
Okay, I think team, you have done a good job. I think we have been able to resuscitate this patient. If you take this patient as 60 kg, you can give about 2 liters of fluid, and then let's reconnect in an hour once we have got the investigations, and then we can decide further. Is that okay?
Sure, definitely. I will do that.
Okay, anything Dr. Milind you want to know from our side? I am sitting here. You can give me a call anytime, even if whenever you think there's a problem with the patient. Otherwise, I will connect with you after 1 hour.
After fluid resuscitation and after antibiotic bolus, I will call you again after half an hour with new ADG.
Thank you.
Definitely, we will discuss further.
And as what we have discussed, sister is sending you all the discussion points on the software. You can already see them, and if you want, you can take a printout and put it in the patient file, or you can keep it for your record in your digital record system. Okay?
Sure.
Thank you, Dr. Milind. Thank you very much. Thank you. Okay, so that's how a typical ICU works in our intensive care in Gurgaon. I'm heading critical care for Fortis, but that's also the way intensive care unit has to run in every part of the country. It should not be different in a district hospital. It should not be different in a sub-district hospital. It can go remote. You can reach anywhere. We have sites in Kathmandu, we have in Bangladesh. The beauty of the system is you can reach anywhere. And that's what we all keep on discussing in healthcare about how do you reach the last person? How does the last person get access to the specialist? See, we all have junior doctors, but we all know, I'm a doctor, I'm sure there are a lot of doctors here. We know there's a years of experience and practice that you need to become a specialist. And when we were junior doctors, there's a level of training that we got, and please, we have to accept that a resident doctor can go to a certain level, then a senior doctor has to supervise the care. And that is where the benefits of the systems and the telemedicine can give to the patient. Thank you very much.
Thank you very much, Dr. Dewan.